Hello, my name is Jacob Deweys. I'm one of the clinical leaders here at GE Healthcare Cardiovascular Ultrasound, and welcome to another one of our Vivid Talks. Today, we're going to be talking a lot about some of our Vivid Heart applications around left atrial quantification, left atrial strain, LA strain, and 4D LA volumes, or what we call 4D LAQ. But first, let me introduce our speaker for today. This is Dr. Aasha Gopal is a non-invasive cardiologist at NYU Langone Cardiology and is an associate professor of medicine at NYU Long Island School of Medicine and has more than 25 years of cardiac imaging experience. She's actively involved in research. She's an investigator in clinical trials, looking into new treatments for heart valve disease and the role of cardiac imaging in managing valvular heart disease and conditions that affect left ventricular, right ventricular, and atrial function, which brings me to the topic she will be discussing for us today, which is left atrial quantification using 4D LA volumes and left atrial strain in clinical use. So I will pass it over to you, Dr. Gopal.
Thank you very much, Jacob, for that introduction. My only disclosures are shown on this slide. So the topics that we're going to cover today are basically past methods of LA quantification and diastolic function assessments, limitations and gaps of old methods, difficulties of analysis of diastolic dysfunction, and advantages of what 4D LA volumes, what does that bring to the table? And lastly, advantages of LA strain analysis. Now, understanding left atrial size and function is important because it gives us a glimpse into the diastolic properties of the left ventricle. Furthermore, left atrial pressure and compliance influences pulmonary capillary wedge pressure, or the afterload that the right heart faces. So obviously the gold standard of all of this is to really find out what is the left atrial pressure, to be able to estimate that in the best possible way and to try to evaluate it serially. So linear AP dimensions with M-mode echocardiography, we know that this is a time-tested method. They're very easy to perform and can be done automatically, as shown on this slide. You see that these are automatically derived LA dimensions. The M-mode echocardiogram obviously has excellent temporal resolution. However, we know from experience that they can be inaccurate because it is very difficult to align the M-mode cursor in such a way that it's perpendicular to both walls of the left atrium. You see on the left-hand side that it's perpendicular to the medial wall, but not the far wall. Here, the same AP dimension is now perpendicular to both walls, and this is a 2D method. And but best of all, this is automatically derived. So this is possible by feeding a large number of parasternal long axis views to the system and applying machine learning algorithms. Automation is really the key to improving workflow and making quantitation practical on a daily basis. So since the left atrium enlarges asymmetrically, the AP linear dimension by M-mode or 2D echocardiography underestimates left atrial volume. Using linear dimensions, left atrial enlargement was correctly diagnosed only 46% of the time, whereas left atrial volume increases that detection rate to 76%. Now, addition of other planes, a third plane, for example, improves the accuracy of volume estimation. However, geometric assumptions, foreshortening, and interobserver variability are still drawbacks of this method. Since the volume of the left atrium is influenced by several factors, including the left ventricular and diastolic pressure and compliance of the chamber, can we predict left ventricular and diastolic pressure and left atrial pressure by studying the velocity of blood flow across the mitral valve by spectral Doppler. So these are now routinely performed, but once again, machine learning dramatically improves the workflow. Here you can see that the E and the A velocities, the EA ratio and deceleration time are all automatically derived and averaged over 3 heart cycles. So this really improves diastolic function assessment on a daily basis. Similarly, you can see that velocity time integrals can be automatically traced to show us the peak and mean gradients. Now, if these are elevated, they may reflect intrinsic mitral disease and therefore do not accurately reflect left ventricular diastolic properties. Now, one of the drawbacks of interpreting mitral inflow Doppler patterns in isolation is that they can be very similar in both normal and severely diseased left ventricles. So all of you have heard of pseudonormal patterns, and they can be identified only if sequential exams on a given patient are available. However, in the absence of sequential data, these patterns must be integrated with those from other sources, such as the pulmonary veins, which themselves, and here is an example of a pulmonary venous Doppler pattern. Now, these can vary actually from vein to vein. You might find a normal pattern in one vein, such as this one, but an abnormal one in another. So that is the drawback of some of looking at the velocities from the of blood flow. So tissue Doppler analysis of the medial mitral annulus and the lateral mitral annulus gives us information on the velocity of motion at the level of the wall itself and yields many useful secondary parameters shown on the slide. You can see the IVCT, the MCO, mitral valve opening, isovolumic relaxation time, and ejection time. But like everything else, it cannot be interpreted in isolation. It must be integrated with the blood velocity data. And of course, there are the traditional drawbacks of tissue Doppler, the angle dependency that must be remembered. Now, color M mode flow propagation velocity combines the excellent temporal resolution of M mode together with the spatial color Doppler map of mitral inflow. The healthier the ventricle, the more robust is the suction, and therefore the steeper the slope. And conversely, the more diseased the ventricle, the flatter the slope. However, this parameter also needs to be integrated with mitral inflow E velocity information to be clinically useful, since patients with hypertrophic obstructive cardiomyopathy can have flow propagation velocities that overlap with the normal range. So these are some drawbacks of old methods. In order to address the limitations of the older methods, new 4D methods of LA quantification and diastolic function assessment are available. Here, a 4D image is being acquired where the left atrium is fully covered. It can be either a full volume or a zoomed acquisition. The frame rate should be 12 or higher. This is for a transthoracic application that is available on the Vivid E95 and EchoPack. Here you're looking at an image looking down on the mitral valve with the left ventricle excluded from the 3D data. So once the 4D acquisition is available, 4D auto LAQ can be automatically launched, as you can see here, it's highlighted. So once 4D auto LAQ has been launched, the 4D data is depicted in 3 equiangular views that vary by 60 degrees each. You can see that on the short axis views on the extreme far right. So in that quadrant, the 3 60-degree views can be visualized. So the last is a short axis view at the level of the blue plane. All you have to do now is to align these views by either moving the lines or the images such that the long axis coincides with mitral coaptation point in each view, and such that the blue plane passes along the mitral annulus. And when you do that, you can then, the views are aligned. And after alignment, the system automatically detects the left atrial walls and traces the contours. You can review the time events as well as the contours and adjust if needed. So you can then review and edit the contours detected in the long axis view by rotating the cross-section view around its axis. You can see that in the last two panes where we're rotating and viewing the contours in the views below and adjusting them if necessary. So once finalized with all the adjustments, you can enter the results stage. Now you get three slices. One is a coronal section on the top. The other one is a sagittal one. That's the middle panel. And then you get a short axis cross section at the bottom. You also get a volume model, as you can see here, and as well as a curve. And from the curve, various volumetrics as well as strain parameters can be derived. And we're going to go through them in detail. The volumetric curve shows us three basic functions of the left atrium: the reservoir function, the conduit function, and the contractile function. The emptying volume is the difference between the maximum volume and the minimum volume. If you take the emptying volume and express it as a percentage of the maximum volume, then it is known as the left atrial emptying fraction. If you take the emptying volume and express it as a percentage of the minimum volume, then it is known as the left atrial expansion index. Both these measurements are of the reservoir function of the left atrium, the difference between maximum and minimum. The conduit function of the left atrium can be measured by taking the difference between the maximum volume and the pre-atrial volume and expressing it as a percentage of the maximum volume. Now, lastly, the left atrial contractile function can be measured by taking the difference between the pre-atrial volume and the minimum volume and expressing it as a percentage of the pre-atrial volume. So that is the last function of the left atrium. Now we can correlate these three phases of left atrial deformation to the timing intervals on the mitral inflow spectral Doppler profile. The reservoir phase begins with mitral valve closure up to mitral valve opening. It includes isovolumic contraction, ejection, and isovolumic relaxation. The conduit phase starts from the mitral valve opening up to the onset of atrial contraction in patients with normal sinus rhythm. If the patient has atrial fibrillation, it continues until the end of ventricular diastole or mitral valve closure. The contraction phase starts from the onset of left atrial contraction till the end of ventricular diastole or mitral valve closure in patients with sinus rhythm. At each phase, there is a close interaction between left atrium and left ventricular function. Since the left atrium expands with the reservoir function, it is influenced by left atrial relaxation and compliance, and it's modulated by left ventricular systolic function through the descent of the left ventricular base. Now, during this phase, the fibers are being stretched, and so the final length is greater than the initial length and is therefore expressed as a positive number. The conduit function is reliant on left ventricular diastolic function, which includes both the suction force dependent on left ventricular relaxation and left ventricular chamber stiffness. Since the left atrium is emptying passively, the fibers are shorter in the final position, and therefore this is expressed as a negative number. Left atrial contractile function is based on left atrial contractility and LV end diastolic compliance and pressure. Since the left atrium contracts actively, the final fiber length is shorter than the initial fiber length and is therefore expressed as a negative number. The loss of this function can result in a 20 to 30% decrease in left ventricular stroke volume, which explains why some patients become symptomatic when they develop new onset atrial fibrillation. The volumetric assessments of left atrial strain are not based on speckle tracking, but rather on longitudinal and circumferential length during the different phases. Now, radial strain is not assessed for the left atrium since it is a thin-walled chamber, but you can get both longitudinal as well as circumferential strain. So you can see here from this table that longitudinal and circumferential strains can be assessed volumetrically during all three phases, the reservoir phase, the conduit phase, as well as the contraction phase. Now, what are the advantages of strain compared to volume? Left atrial volume has long felt to reflect the chronicity and the severity of left ventricular diastolic dysfunction. However, volume is an insensitive marker of the early phases of diastolic dysfunction. On the other hand, left atrial reservoir strain may be more a sensitive way of diagnosing left ventricular diastolic dysfunction, rating its severity, and monitoring the effects of treatment. It can be obtained volumetrically, as we saw, using 4D auto LAQ, or it can be obtained by speckle tracking echocardiography, which is less affected by loading conditions. So again, volumetric measures are affected by loading conditions, and speckle tracking echocardiography is less affected by loading conditions. And that is one of the advantages. So this method is largely automated and therefore very practical in a busy clinical setting. And you're looking at a 4-chamber view, but you can also use a 2-chamber view, provided the LA is fully visualized. Frame rates of 40 frames per second or higher are required with no upper limit. ECG markers, which you can see at the bottom, can be manually adjusted. The region of interest can be specified with 3 clicks, as you just saw, and tracking can be improved by adjusting endocardial and epicardial borders. And there you see the final strain curves for the left atrium showing all 3 phases of left atrial contraction. So left atrial strain curves from single plane as well as biplane views can be obtained easily, showing the reservoir strain, which we said was a positive number, and the conduit and contractile strains, which are negative numbers. So this is available only for transthoracic echo and not for transesophageal echo. So the strain rate, which expresses the speed of deformation, can also be calculated for each phase and has the same sign as the strain for each phase. So a positive peak strain rate during the reservoir phase, a negative peak strain rate during the conduit phase, and again, a negative peak strain rate during the contraction phase. The reservoir strain is positive because the final value is greater than the initial value. The conduit and contraction strains are negative because the final value is lower than the initial value. You can see that here nicely displayed. Now, so far, I have shown you curves that use the R wave as the 0 strain reference. So starting off with the R wave, when you do R to R gating, you can see that the reservoir strain in this patient is 27%, right? Is a positive number. Now, if you gate differently and decide to use P2P gating, the strains are still computed using the same initial and final endpoints and have the same sign, but their values are slightly different. The reservoir strain is now 24% as compared to 27% using R2R gating. Now, most software packages recommend R2R gating since R wave detection is easier than P wave detection. So that's just something that you should be aware of, the type of gating that you're using. Now, just as we previously saw strain data being derived from volumetric data using 4D LAQ, we see here that volumetric data can automatically be generated from AFI or speckle tracking in a phasic fashion. That's what we see here. So what do all these numbers mean? So this paper by Thomas et al. Clearly shows that left atrial strain is more sensitive than LA volume index for detecting diastolic dysfunction, which in turn is more sensitive than spectral Doppler and tissue Doppler indices. You see going from left to right on the slide, normal, and then early stage 1, late stage 1, early stage 2, late stage 2, and so on. You see that the left atrial strain can be done in a graded fashion. And so abnormalities occur much faster with that. Whereas the left atrial volume index really doesn't become relevant reliably till late stage 2. And the E to A similarly can stay normal till almost early stage 3, and so on. So this slide very nicely demonstrates the fact that left atrial strain is a much more sensitive way of detecting diastolic dysfunction. Now, some clinical scenarios where left atrial strain may be helpful. In hypertension, abnormal left atrial strain values preceded structural left atrial changes. In heart failure, left atrial strain differs in patients with diastolic dysfunction and those with clinical heart failure preserved ejection fraction. So here you see an example of a transplant patient, a heart transplant patient, in which left atrial strain may correlate with acute rejection. Another intriguing application may actually combine left atrial strain at the conduit phase with the tricuspid regurgitation velocity to predict pulmonary capillary wedge pressure, which provides an indirect measure of left atrial pressure, which is the holy grail that all of us aspire to detect by echocardiography. So these are also some studies that indicate that changes in left atrial strain may predict when a patient goes from normal sinus rhythm into atrial fibrillation. It may also be useful to predict outcomes in patients with mitral regurgitation and mitral stenosis, as well as aortic stenosis, and lead to more timely intervention. So, what are the key takeaways and conclusions? First of all, left atrial function is an important biomarker for several cardiovascular diseases, as we just showed you. And it's a strong predictor for clinical outcomes. If you're going to use strain, it is AFI strain is a good way to go because it's portable, non-invasive, and it is based on speckle tracking echocardiography. It's fast, reproducible, has less interobserver variability, and it does follow the consensus document from the ASC as well as the European Society's task force You need raw data to analyze the images. Left atrial function can be assessed by using 4D LA volumes. You can get very precise quantification of the reservoir, conduit, as well as there's a typographical error on this slide. It should say reservoir, conduit, and contractile functions of the left atrium. Limitations of left atrial volumes by 2D echo are obviously geometric assumptions. You can foreshorten the left atrium. And of course, you have interobserver variability. Now, left atrial volumes by 4D are not limited by geometric assumptions. However, image quality is a factor. Nevertheless, it is a more sensitive method for detection of left atrial enlargement. And I showed that very early on. 76% of the time you can detect when the left atrium has enlarged, compared to only 46% of the time when you use linear dimensions. On the other hand, strain assesses early changes in atrial mechanics that occur with atrial enlargement. It's simple, automated. When you use AFI, it's reproducible, has much less interobserver variability, and it's less influenced by loading conditions. And so, although left atrial strain has not yet made it to the clinical guidelines, I think it's a very useful way of assessing serial changes in a patient, particularly if you're worried that the patient has had episodes of heart failure with preserved ejection fraction, and you want to keep them out of the hospital.
Thank you, Dr. Gopal, for that talk. We're going to go to the questions here in the chat. And if you have any questions, please feel free to put those in the chat. And if we can't get to them, we will text or type them in there. And so as I'm looking here, there is a question around how you practice and a little bit about what's being ordered. So do you receive echo requests specifically for LA function or diastolic function specifically, or do you perform LA functional measurements regardless of the request or indication?
So in our laboratory, we assess diastolic dysfunction routinely in everybody that comes into the lab. So all of the modalities that I showed you earlier, we perform in a very standard way. We look at flow propagation velocities. We look at E and A velocities. We look at velocity profiles. We look at tissue Doppler, and we use all the traditional criteria and the guidelines to make a statement about left atrial function. However, or left atrial pressure rather. However, we find ourselves many times kind of equivocating on that because, again, it requires integration of data from several different sources, the pulmonary veins, for example. So we are now trying much more to try to assess left atrial function. We certainly report left atrial volumes that are indexed to body surface area. We always make a comment about exactly what that left atrial volume index is. Certainly in our patients with heart failure, preserved ejection fractions, those patients are coming in from the heart failure service where they want more sort of detailed assessments of left atrial function. So currently, that's how we're handling it. So we try to assess left atrial function in a more comprehensive manner when it is specifically requested by the referring physician.
Yeah, I think, and that's one thing I loved when you started off the presentation with. Automation is important and some of the kind of AI tools. And that's one thing, we're really trying to work on is, there is a lot of process and measurements and things that we can do to assess LA function and diastolic function. And so how do we kind of streamline some of that so that we can get the information? And the echocardiogram as a whole is becoming more and more robust every single year, it seems. And so it's nice to kind of see that, you know, the LA Strain tool can give you your biplane LA volumes, and kind of the ease of use of automation with 3D. And so it's a really exciting time. Let's take another question. This one says, do you perform imaging for LA specific views, or is using the standard 4-chamber and 2-chamber when you get the LV sufficient? Or so I guess they're asking, do you get a 4-chamber, 2-chamber that concentrates on the LV, and then another 4-chamber, 2-chamber that concentrates on the LA?
Yeah, what we encourage our sonographers to do is, again, practice looking at left atrial function and try to work it into the routine. So if you're getting a 4-chamber view, try to get a 4-chamber view that is able to visualize the left atrium completely. And if you get a good image, then try to go into AFI and get strain measurements as well. So we try not to deviate from the usual protocol if we can. I think that's a way of trying to get new technology incorporated into the workflow as easily as possible. Certainly, if the referring physician has specifically asked for the left atrium to be quantified, then obviously we're get LA specific views and make the adjustments. But if that's not the case, then we'd rather work with the views as they are taken in the regular protocol.
Excellent. Well, I think that's all the time we have for questions. And if there is any questions we didn't get to, we'll try to answer those in the chat function. Or you can go ahead and reach out to your local GE representative, depending on your area. And I just want to thank everyone for joining us today on this Vivid Talk. And again, thank you very much, Dr. Gopal. It's always a pleasure to see you and hear from you.